This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, it's Jeff Ratliff with Thomas Jefferson University and the Neurology podcast. I'm here with Ron Postuma from the Neurological Institute in Montreal to talk about a paper he and his colleagues published in Neurology titled IGLON5 Frequency in Idiopathic REM Sleep Behavior Disorder. Following reports of REM behavior disorder occurring in patients with antibody-mediated syndromes that are associated with movement disorders, Ron and his colleagues looked to a large cohort of patients with polysomnogram-confirmed REM behavior disorder to explore the frequency of autoantibody positivity, specifically looking at the frequency of IGLON5 antibodies. We wanted to invite Ron to talk about the study and some of the implications for those of us who care for patients with either sleep disorders, movement disorders, or perhaps both. So Ron, welcome to the podcast.
Great to be here.
So Ron, let's start with a high-level summary. What did this study find with regards to the frequency of IGLON5 or other antibodies in this large cohort of patients with REM behavior disorder?
This is a cohort designed to study synucleinopathy, prodromal stages of synucleinopathy, Parkinson's disease, dementia with Lewy bodies, etc. It's the North American Prodromal Synucleinopathy Consortium. And we decided to run just on these routine patients a series of antibody tests, including IGLON5. And essentially what we found is that 1% of this unselected cohort was positive for IGLON5.
And so you just touched on it, and I think it would be helpful to talk a little bit more about this cohort. And so we know that patients with idiopathic REM behavior disorder do have this elevated risk of developing alpha-synuclein-mediated neurodegenerative diseases such as Parkinson's, dementia with Lewy bodies, MSA. And so is this a cohort of patients, as you mentioned, they're being followed given this association? What else can you tell us about the clinical characteristics of the patients in this cohort that you were getting these samples from?
Right. So idiopathic REM sleep behavior disorder means that you're acting out your dreams when you're asleep. And so we're supposed to be paralyzed when we dream. In RBD, you lose this. And these are people who have just that wrong apparently with them. In other words, they don't clearly have Parkinson's, dementia with Lewy bodies, multiple system atrophy, etc. And so we know that RBD by itself is a very strong risk factor for these synucleinopathy conditions. And over 80% of these people will develop one of those conditions. And so the purpose of the NAPS cohort was to find a large cohort of these people, follow them over time, and looked for aspects that could predict neurodegeneration, particularly synucleinopathies. So really, these are what we would consider regular, off the street, normal REM sleep behavior disorder patients, all of who had a polysomnography proving their diagnosis. So I think a relatively unselected cohort of RBD patients.
Very typical of patients that might walk into our sleep clinic or our neurology clinic with dream enactment behavior. And so we've talked about that link between REM behavior disorder and Parkinsonian disorders. So let's bring in IGLON5. So listeners may recall some interviews from the past in which we've discussed some of the clinical syndromes associated with these antibodies. I spoke with Charles Geitch back in 2021 about the movement disorders seen in patients with these antibodies. Jason Crowell spoke with Charles again earlier this year about a clinical severity scoring system for patients with IGLON5 antibodies. And so, Ron, our listeners may have heard some of this before, but we know that there are some other sleep symptoms associated with patients with IGLON5 antibody syndromes. Can you teach us a little bit more about what did we know previously about sleep and IGLON5 antibodies, and then bring us up to speed a little bit about some of these emerging cases that prompted you all to do this study in particular?
One thing to remember for everybody, this is brand new. The first large-scale descriptions of this syndrome were really 2014, and the more detailed clinical studies were only coming out 2017, 18, 19. So this is a brand new area, so we're learning a lot. The general description of these cases is best summarized as a destruction of the sleep-wake system and everything that you can associate with a sleep-wake system. So these people typically present with apnea, non-REM parasomnia, so that means sleepwalking, sleep talking, getting up and doing very complex things, insomnia, somnolence, and REM sleep behavior disorder. And the general picture, I think, has been that of a relatively rapidly progressing, usually in our heads, a relatively subacute presentation of this complete sleep state breakdown. Then it's associated with a whole lot of other features such as extraocular movements and chorea and cerebellar abnormalities, which have been summarized as well. And so this is the picture that we have in our head, this sort of total sleep destruction, relatively subacute. Whether that is true or not, I'm not so sure if it's that way all the time.
So really having our clinical suspicion up when there could be any number of different sleep symptoms, especially those that seem to be progressing on a subacute timeline with a pretty rapid accumulation of deficits. So going back to the NAPS cohort that you described earlier, I want to get into a little bit of the methodology of the study. So it sounds like your team had previously collected and subsequently frozen serum samples from this cohort. And it was from these samples that this study went to look and try to detect antibodies, if I have that correct. So can you talk us through how you took the specimens and specifically sought to explore more about whether there's IGLON5 or other autoantibody positivity in these patients?
So as part of NAPS, we systematically collect right at baseline serum samples, and they're basically stored. And we started to realize that these cases were coming in. I'd had a grand rounds where I'd seen one, got the diagnosis, and then started to think, oh my goodness, how many might we be missing? And so we decided to do it systematically. So we had them sitting in our freezer, and we approached Andrew McCown from the Mayo Clinic, who's really one of the leaders in the testing of this, has a well-established assay. And what we wanted to do was not just do IGLON5, but to send it for IGLON5 and then the potassium channel antibodies. So Casper2, LGI1, DPPX. And after a very long and ultimately tragic and rather distressing bureaucratic delay of 18 months to sign MTAs, we finally got those samples sent. And then Andrew, he runs an initial cell-based assay screen. And then if they are positive, there's a confirmatory assay with a tissue immunohistochemistry. So we're relatively certain that what we're seeing as positive samples are in fact positive samples.
So we have this prior knowledge of parasomnias in patients with IGLON5. And now in this cohort serum sample testing, you and your team did identify a finite number of cases of seropositivity. Can you tell us a little bit more about the clinical features of those cases that you ultimately did identify through this serum testing protocol you just described?
So first of all, the potassium channel antibodies were relatively negative. There were some preliminary positives, and then there was ultimately one very low titer confirmed positive Casper2. And for many reasons, we believe that this is an incidental finding. This patient has very clear symptoms of Parkinson's disease, positive DAT scan, abnormal smell, looks like a classic IRBD evolving to synucleinopathy. Then there were 3 IGLON5 cases, so that's just under 1%. We actually think that one of them may in fact also be an incidental case. We can't give much details on this case, but based on evolution, synuclein seeding assays, response to a trial of therapy, this patient also looks quite classic synucleinopathy. The 2 cases, though, I'm pretty sure are the real deal. And they're somewhat tragic to hear about, actually. So the first case is a case who really looked quite typical. So this patient presented, he had some mild apnea-hypopnea index of 9. I mean, that's a lot of the population. He looked perfectly fine on examination, had olfactory loss. I would say looked very typical. I didn't see this patient personally, but looks like very much one of our typical patients. A year later, he gets esophageal cancer, and post-operative, he has a rapid decline and develops a delirium. And then at this point is getting what looks like an IGLON5 picture, sleep state disruption, insomnia, somnolence, acting out the dreams. But he's lost to research follow-up because of his esophageal cancer. So none of us are seeing this fellow anymore. And ultimately, he died in that state. So we're pretty sure that he was a case of IGLON5. But boy, that esophageal cancer in postoperative state is a major confound in making the diagnosis. The other one I personally saw, and this was a patient who had a 3-year history of REM sleep behavior disorder and had some clues, I will say, at the first visit. So had a history, at least, of non-REM parasomnia. This had resolved by the time I had seen him, but was complaining bitterly about poor sleep, insomnia, couldn't fall asleep, somnolence during the day, also had some apnea. There was a possible antidepressant association, so that always makes you wonder if it's really truly a synucleinopathy. They usually are. Had normal olfaction, and I wondered about some subtle cerebellar signs. This is way back in 2018, so the IGLON5 stories are really just breaking, and I must say, I don't think it was particularly on my radar at that time. But the year after, he came back and looked perfectly fine. Everything was basically gone. He had a little bit of RBD, but was otherwise perfectly well. And it was the year following that, so the third year, he comes back, he looks again like this sort of concerning, some orthostatic hypertension, maybe some subtle cerebellar features, and I'm going, this guy looks like he might be going to MSAC. Come back soon. But at this point, they'd elected to stop research follow-up, and we're seen outside. And in that outside neurology service, they ultimately documented horizontal gaze abnormalities, chorea, gait instability. He ultimately died of COVID 6 months before we had the results of the antibody testing, somewhat tragically. And so both of these cases had something, but there were some confounding things in both of them that really threw us off, I think.
And if we want to try to zoom out, I think you're spot on in that we have to be cautious. We've got finite number of cases and the ability to follow through on the full natural history of what happened with these patients has been limited by other diseases that have sort of truncated their clinical course in their lives, perhaps prematurely. But from your perspective in looking at this data or thinking broadly about what we are learning relatively recently about IGLON5, do you see lessons to be learned here? I think you and I both are frequently seeing patients coming in either from sleep medicine or have this new diagnosis of REM behavior disorder. And maybe the goal of that consult is to make an assessment for subtle emergence of a Parkinsonian disorder. Would you advise that I or our listeners who are seeing these patients adjust their clinical approach in any way if it seems like as you said, sort of a more run-of-the-mill idiopathic REM behavior disorder patient who's showing up in their clinic for the first or second time? Or should we be on the lookout for some of these concerning features that you've touched on?
Of all the papers I've written, this one makes me the most uncomfortable, I would say, because I really don't know what to do with this. I agonize over this myself. So I think you could make one argument, I don't think it's the correct one, that we should just routinely test these. Remember, these are treatable conditions. So important to emphasize that IGLON5 may be less treatable than the other conditions, okay, which are very, very treatable. And many IGLON5 patients will progress regardless of treatment, but there are reports, quite convincing reports of improvement with immunosuppressive therapy. So given that this is 1% of an otherwise unselected population and there's a treatment response, should we do it routinely? Well, now we're running into trouble, of course, with false positives, exposure to immune therapy in patients who otherwise wouldn't benefit from it. You can just imagine. I do think a selective approach is warranted, but don't wait for the super classic subacute sleep state meltdown. These patients had atypical features, but they didn't have that many atypical features. So even the most obvious case, that last one, did look fine at one point. So I think my central message is you're used to seeing synucleinopathies. And so if you're seeing a person with olfactory loss and constipation, subtle motor features, maybe a positive DAT scan, who knows, whatever it is, and otherwise looks routine, I don't think I would order that test. But if you're seeing these atypical features, so there's a lot of non-REM parasomnia associated, the patient's walking out of bed, or a subacute apnea, or then some features on exam that look a little off, I would have a quick trigger on checking for IGLON5 and for the Casper2, LGI1, DPBX antibodies, because those ones we really don't want to miss.
Thanks, Ron. I think you touched on some important points. One is this conundrum we see in lots of other scenarios, right? We have a test. There's always going to be a risk of false positivity. And so if we're dealing with something that is, relatively rare, like you said, on the order of 1%, if we're going to start testing everybody, we're going to start to increase our risk of therapy exposures and all the things that come with that. But it sounds like clinically, these patients are challenging. That case that you mentioned where one visit, you can see these clinical features of this breakdown of sleep architecture, and then a follow-up visit where they look relatively okay, and then they come back a subsequent visit and you're seeing these clinical features again. And so still, it sounds like one take home perhaps is if it looks like a more typical Parkinson's disease clinical syndrome, our suspicion that that is an emerging IGLON5 is probably going to be low, but certainly we have some of these clinical features to look for even at the beginning and to not wait around until it has sort of become more full-blown, so to speak. So I think there's absolutely a lot of wisdom there from this study and from your experience. I've been speaking with Ron Postuma from the Montreal Neurological Institute about his paper in Neurology, Neuroimmunology, and Neuroinflammation titled IGLON5 Frequency in Idiopathic REM Sleep Behavior Disorder. The paper can be found online now on the journal's website.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.